Hello and welcome to the topic Gastroesophageal Reflux Disease in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define gastroesophageal reflux disease, discuss the pathophysiology of gastroesophageal reflux disease, describe the clinical presentation of gastroesophageal reflux disease, outline the investigations, and discuss the management of gastroesophageal reflux disease. Let's get started. Gastroesophageal reflux disease is a chronic condition in which the stomach contents rise up into the esophagus, resulting in either symptoms or complication. Gastroesophageal reflux disease, or GERD, occurs when the stomach acid frequently flows back into the tube connecting the mouth and the stomach, which is the esophagus. This backwash or acid reflux can irritate the lining of the esophagus. The pathogenesis of gastroesophageal reflux disease is complex and it involves changes in reflux exposure, epithelial resistance, and visceral sensitivity. The gastric refluxate is a noxious material that injures the esophagus and elicits symptoms. The reflux disease is usually caused by the ring of muscles at the bottom of the esophagus or gullet becoming weakened. Normally, this ring of muscles open to let food into the stomach and closes to stop the stomach acid leaking back up into the esophagus. If the intraesophageal pH is less than 4 more than 10% of the time, the patient is considered to have pathologic reflux. So what are the symptoms to look out for? One would complain of having burning sensation in the chest, which is known as heartburn, usually after eating, which might be worse at night. One may also complain of chest pain, difficulty swallowing, regurgitation of food or sour liquid, sensation of a lump in the throat, having chronic cough, laryngitis, new or worsening asthma, and disrupted sleep. The physician might be able to diagnose gastroesophageal reflux disease based on physical examination and history of the signs and symptoms mentioned. Alarming symptoms include difficulty swallowing, unintentional weight loss, vomiting blood especially, and this indicates the need for an endoscopy. The most accurate diagnostic test which is used for the diagnosis of gastroesophageal reflux disease is an ambulatory acid monitor, which is useful, and it does not cause any esophageal damage. Now, let's look at the functional tests, which will help us identify the problem as well as diagnose it. We have esophageal manometry and esophageal pH monitoring, which are considered essential before performing an anti-reflux surgery. The esophageal pH test is commonly used to help confirm the diagnosis and to identify the cause of various symptoms. Esophageal manometry, however, it's an outpatient test that can identify the problems with movement and pressure in the esophagus that may lead to problems like heartburn. An endoscopy with biopsy is one of the most common tests physicians use to confirm a diagnosis. And to confirm this or to check for complications, an endoscopy with biopsy is done. A thin, flexible tube equipped with light and camera is placed down the throat to examine the inside of the esophagus and the stomach. The test results can be normal when reflux is present, but an endoscopy may detect inflammation of the esophagus, which is esophagitis, or any other complications which may reflect the action of acid reflux. An X-ray of the upper digestive system can also be done, and this can be done after taking in a drink of a chalky liquid that coats and fills the inside lining of the digestive tract. The coating allows the doctor to see a silhouette of the esophagus, stomach, and the upper intestine. One may also be asked to swallow a barium pill that can help diagnose a narrowing of the esophagus that may interfere with swallowing. Now, when it comes to management, we can begin with prescription of histamine 2 receptor blockers, and these include famotidine or nizatidine. These medications are generally well tolerated, but long-term use may be associated with a slight increase in the risk of vitamin B12 deficiencies and bone fractures. Other prescriptions could be proton pump inhibitors. These include esomeprazole, lansoprazole, omeprazole, pantoprazole, and rabiprazole. Although generally well tolerated, these medications might cause diarrhea, headache, nausea, and vitamin B12 deficiency. Chronic use might increase the risk of one having hip fracture as well. Other than that, you could also prescribe medications to strengthen the lower esophageal sphincter, and this means prescribing baclofen, which may ease gastroesophageal reflux disease by decreasing the frequency of relaxations of the lower esophageal sphincter. So when it comes to management, there is a procedure that can be carried out which is known as nasal fundoplication. Here the surgeon wraps the upper part of the stomach around the lower esophagus, and this enhances the anti-reflux barrier and can provide permanent relief from reflux. So in summary, we have understood that gastroesophageal reflux disease is a structural and a functional problem which leads to the stomach contents rising up into the esophagus. We have understood the pathophysiology and causes of gastroesophageal reflux disease, the common presentation one would come in with, how to make a diagnosis based on physical examination as well as investigations such as esophageal pH monitoring and esophageal manometry, other imaging studies which may be useful in confirming the diagnosis, and finally an endoscopy approach which will be useful to not only detect the abnormality of reflux mechanisms but also the lining of the esophagus and the stomach. Last but not least, management, which could be medical as well as there's a surgical approach of managing gastroesophageal reflux disease called Nissen fundoplication. We have come to the end of this topic. Thank you.